this is a case now moving away from epilepsy to kind of a non-epilepsy use of the ROSA that we found useful here. This is a patient, a 12-year-old, came in with headache, acute onset lethargy over the previous 24, 48 hours. He was rather obtunded on an examination, very nauseous, throwing up, difficult to arouse. He had no focal deficits when you could get him to wake up long enough to get him to do anything, but he would quickly fall asleep. Imaging, you can see here he has a tectal enhancing lesion consistent with a tectal glioma. Because of its enhancement, though, we were concerned that we were concerned about the grade of it, whether it was just a low grade like your classic tectal glioma or if it was something higher. He also had the issue of hydrocephalus that needed to be treated. So in this instance, we have a patient who could benefit from two different minimally invasive procedures. One being a stereotactic biopsy of the tectal lesion, the other being some kind of CSF diversion procedure. And for these patients, they're great candidates for the endoscopic third ventriculostomy, where you can avoid implanting a ventriculoperitoneal shunt because it's just an obstructive hydrocephalus. So the ROSA is great for doing biopsies. Anybody who's ever tried to biopsy the tectum can know that this is a very difficult place to get a needle in. You have to. This is not straightforward for needle biopsies. This is about the deepest, one of the more eloquent portions of the brain, and we have found, though, again, using the ROSA for this has been effective. We've done tectal biopsies now on 3 different patients with great success, not had any issues, and we were able to hit the target exactly every time. So in addition, we're able to go in and do the ETV at the same time. We use the ROSA to plan our trajectory. We also use the ROSA to hold our endoscope and guide our endoscope in, and we're able to then do the ETV through that. There's the advantage to using the ROSA for doing our endoscopic third ventriculostomies. It does provide a remarkably stable arm for us. It enables a single surgeon to do the procedure rather than having multiple ones involved. Any other time you do an endoscopic procedure, you're going to have one surgeon holding the endoscope and driving it, the other one having to work the wire through it. When the ROSA is able to hold it, it lets the surgeon just focus on doing the fenestration itself. And the other thing is when we're able to do this, anytime we use this ROSA, our incisions have always been closed by a single suture, just a single stitch, both from the ETV site and from the biopsy site, which is the least invasive way possible. So this is just kind of going through the setup and how we use the ROSA. First, we do the planning on the computer. This can be done on the laptop and loaded into the robot, or it can be done on the robot itself. This is what the screen is. You can see our planning for the biopsy on the upper screen, and then on the lower one, you can see our planning for the ETV. We position the robot near the patient's head. This isn't actually the patient whose films I've shown you. This is another one just to kind of show the process that we go through. It has to be a certain distance away from the robot. We use a tape rule to measure that out. This particular patient had very short hair, so it looks like we shaved his head. The patient I actually did this procedure on, he had long hair, and we didn't have to shave any hair at all. The patient's positioned in a Mayfield head frame or any other head frame. People prefer the Sugita or whatever else to get it in there. Then there's a laser that we do that scans the face in order to register the patient's position to the robotic arm. Here you can see once we start driving the robot, we step on a pedal and the robot drives into position. You can see the bushing, the instrument holder right there. You can put there's a number of different bushings with different size working ports through there that you can pass your drill bits through, your biopsy needles, your EEG electrodes. I'm holding in my hand there one of the bushings. Here we're drilling a hole through the scalp. This looks like where we're going to this is the endoscopic portion of the procedure. Then once we have the hole, we're able to pass our 3 millimeter pedioscope into the ventricle. You can see us looking at the ventricle there, and I'm able to just, I'm dilating the fenestration. And this was a kid just a couple days ago. This was a kid we actually performed the procedure on right there, of the images that you see. I can put him up there only because he's on our main children's website. So the families agreed. The families agreed to have his picture shown for the success all over the world. Yeah, if you just go to rchd.org, you're going to see the smiling face up there. But within a couple of days, we had a tissue diagnosis, and he had resolution of his acute hydrocephalus, and was going to summer camp the next week. So, one last case. This is another tumor type case. This is associated with epilepsy. You can see how small the lesion is at the right trigone. The little flare signal there. This is a 16-year-old boy who's having just cognitive partial epilepsy, difficulties with math, focusing that would come. They were happening almost daily. They occurred with stress. You can go through. You want is interictal EEG there, kind of confirming its location.
Yeah. Again, it's not very specific, but you can see the amplitudes are a little bit higher over that right side, and seems maximal in the F8 T4 area. And it's basically not very helpful because it's more bisynchronous activity at times. But we have a lesion, so that was probably what helped us.
So here you can see our planning again, where it's a sub-centimeter lesion. We didn't know what it was, so we were able to first use the ROSA to guide a biopsy needle down there. We took a biopsy when it ended up being a low-grade glioma. Once we knew what it was, we replaced that biopsy needle with a visualized catheter, went on to ablate it, and he was initially seizure-free. He's just in the last follow-up visit last week, the family's reporting a couple seizures, but it's markedly reduced.
Yeah, so our goal for this was basically serial MRIs showed a growth of this lesion, and the goal was to biopsy this lesion and see if it truly is a tumor, and then try to ablate it. So by far, we definitely didn't do the part of, I think, in general, to do any more imaging studies like PET to see if there's any other hypometabolism around that lesion, and we decided not to do SEEG based on the request of the family and their epileptologist. So clearly, I think there was some success because his seizures, instead of going up to 10 minutes of being altered and confused, they're now 30 seconds to a minute, very brief, and the parents say he's just like alive. They're very happy. Unfortunately, the seizures are still now 2 times a week, so it means we basically didn't get all of it. And whether it's like a tumor plus cortical dysplasia, and that's something for us to assess in the future. The main anxiety was that, is this growing tumor need to come out, and so we didn't want to. We wanted to biopsy it. So
yeah. Anyways,
that's all of it.
Yeah.
Okay.
So that's all of our cases. I think that was our last slide.
The other part that I found it useful is, even in temporal lobectomies, if it's a non-dominant, we tend to go 6 centimeters back for resection. And what we decided to do, we had a case recently that, her seizures were gastric uprising and then behavioral arrest, very non-specific, non-localizing semiology. Her EEG showed, right anterior temporal. When we actually did a MEG on her, and with the cluster of spikes, they identified a very subtle dysplasia in the mid portion of the superior temporal gyrus. And what we did is, when we planned an SEEG, and we wanted to, 1, make sure if we need to take out the amygdala and hippocampus in addition to that lesion, and 2 is how posterior do we need to go. So we actually, using the ROSA, were able to put an electrode directly into where the dysplasia was identified. And you're not seeing that because this was just done last week. And our activity was exactly on that electrode, perfectly. And then we, depending on how it spread, we planned a posterior border. And then David Gonda basically told me, had we not have this marker, he probably, even if eyeballing it for 6 centimeters, he probably would have not resected accurately. And the other part that was helpful is when they do an open craniotomy, it kind of has a little blood, what is it? It basically leaves a mark for you.
You can see the puncture marks in the brain, which provides
marks,
like kind of a grid along the brain where we place electrodes, and so that there's not as much measuring. You can actually see exactly where you're going.
If I say take to this electrode, then he'll see the the blood mark, and then just resect to there. So that was also helpful, I found.
How about using stereo EEG for functional mapping? So language.
Yeah. So Dr. Chevelle came and gave us a talk, and of course he was an advocate for that. I'm still if it's really in the dominant area for language mapping, I'm not very comfortable. I would be more comfortable with a grid. Obviously, if it's somewhere like anterior to the area, you definitely can, just to get a feel like, is there an activity or not? And you definitely have to start at lower settings and then advance it up. But in general, I have not done that yet. But Cleveland Clinic definitely has done it, but they still also use grids as well.
Yeah, it has been done. We personally haven't, but
it makes me nervous.
Dr. Gonzalez is using ROSA actually to place grids. So he folds them in such a way and then unfolds them. It's he's used ROSA for a number of years, so he's probably one of the few that's able to do that. But I found that fascinating that he's using it to allow that placement as well.
Yeah, no, we haven't tried that.
For grids or strips?
Actually, strips, sorry.
Okay.
Not grids.
Okay.
No, grids are much harder, wouldn't they?
Yeah.
No, strips.
I can see how that works, though. It's just a stereo. I mean, in the end, the ROSA is like a mechanized stereotaxy. We have a lot of flexibility in it's the instrument ports and how you're able to move it to and from the scalp, around the head. It's very easy. There's nothing you can't do. Using a Lexel frame or CRW frame, you can do everything that you could with a ROSA using those frames almost. You just have a lot more flexibility with the ROSA, a lot more ease, and it's much more time efficient.
And the kids just do so well the next day. It's just amazing. It's night and day compared to an open cranie. So, and what's happened is just doing a few, we basically are trying to do more SEEG recordings rather than open craniotomy and grid placements since we've been able to acquire the ROSA.
It's just changing the way we're doing our surgeries.
Yeah.
Here.
Yeah.
And I think one thing that we do differently than Cleveland is that we implant, and then obviously we do the open cranium and do the surgical resection. And I think in Cleveland they basically do the SEEG recording, remove the electrodes, and then have the patient come back in a month later for the surgery.
Yes, that's true. And I think that the large majority of their patients are adult patients. And so, allowing time for the discussion of next steps and, that process, they've found that leaving that time lag in there works best for them with their adult population.
Yeah.
Yeah.
You will love it, I can tell you. It sells itself. I don't even need to sell it for you.
You'll love it. Well, thank you very much, Dr. Shifteh and Dr. Gonda from Seattle Children's and the Epilepsy Group. We really appreciate your time.
Thank you.
Yeah, thank you, guys. Anyone else on the call have any other questions? I know there was a couple late joiners. Anyone else have any questions before we let them go? All right. We'll take the silence as a no. Thank you again. We really
Wait. One more question.
Sorry.
One quick question. What about paraventricular heterotopias that have a spread to the scalp? You often do network use of the ROSA, looking at different parts of the longitudinal fasciculus or something like that?
Well, so that's a good question. We actually had a case that we were going to do in 2 weeks, and we wanted to use SEEG to kind of identify the network, and that's what we did plan to do, except the patient refused. So we are actually going to use SEEG to go to the gray heterotopia and ablate it, and then he letting him know that this might not be, he might continue to have seizures. But it's definitely something that we plan to do. We have not yet done it here.
Yeah, we recommended that. We had a plan for it. The patient didn't want to do SEEG, so he just wanted the heterotopia ablated. We let him know that, he could fail, very likely could fail if that's all we do, because of the risk of missing these unseen dysplasias associated with it. But that's just what they've chosen for this particular patient. But yeah, that's a great use for SEEG. It's a great use for the ROSA, though.
It's easy access to it.
Okay.
Just one other question. What's the response of the parents? Are they coming in expecting open cranie procedure and then are pleasantly surprised by the ability to do this minimally invasively, or what do you see from the parent perspective?
Well, we discussed the surgical plan with them prior to admission. And we basically try to show them pictures of it and describe that it's just a little bit bold, like a few bolts coming out, and then I kind of joke around and say you're going to look like Frankenstein. And they're very receptive. I think they get more scared when you say we're going to take a portion of your skull and open that. So everybody so far has been receptive to it.
I found the most common response that we're getting, actually, I think this is actually broadening the number, or it's expanding the number of patients who are willing to have surgery for their epilepsy. Yeah. I think more often than not, you have patients who they don't want to consider any procedure because they don't want to have a craniotomy done. And now when we're offering, we have this robot, we can do this minimally invasive. It's a couple puncture wounds. It's a short hospital stay, there's not much pain involved. We can frequently use a laser to ablate it. All of a sudden, patients who had been saying no, like this lady we did just a couple weeks ago, she was an adult, but she had been saying no to surgery for 15 years, and now all of a sudden she said, absolutely, I want this done. That's been more often our response. Now, what happens to me now is because of the way the hospitals kind of advertise the robotic therapies and robotic guided therapies and laser and stuff, is I have patients coming in for a Chiari decompression, and the families are all asking me if it can be done with a robot, and and I say no, that's not an application for it. But the families want it done, they're asking about it, and they're aware of it. So
really interesting. Emory, the webinar that we hosted with Emory, they said exactly the same thing. This is actually expanding the number of patients who will consider surgery because it's just far less scary for patients.
Thank you.
Thank you.
Thank you.